Today we are going to talk about the NPTE Gait Deviations made easy. We are going to talk about Trendelenburg gait, Antalgic, Steppage, and Circumduction gait. We already talked about the gaits and the normal gait phases. Now we are looking into the gait deviations. So if you confuse Trendelenburg gait, Antalgic gait, and Steppage gait, this video will make it simple for you. By the end, you will be able to identify each one in an NPT question just from a 2-sentence patient description. So we are going to through the different gait, understand them, and we are going to do some practical NPTE-Style questions. So we will cover this in 3 steps. First, what each gait actually look like, right? Second, the muscles and nerve problem behind it. Third, how it show up in an NPT questions, including the trap answer choices they can give to you. Right, so we are understanding Antalgic gait today, what is it, how it will be shown. Then we are going into Trendelenburg gait, what it would be like, and what is the questions that come from that Trendelenburg gait, and Steppage, and Circumduction, and hip hiking. So by end of the video, we'll be mastering on all this. So any questions coming from these gait deviation, you will be able to answer and get the full mark for that. So first we are going to the Antalgic gait. Antalgic gait is a pain avoidance gait. The patient shortens the stance phase on the painful side because they don't want to bear weight on it for a long time. So what happens with Antalgic gait is there is a pain. For any reason there is a pain. Because of the pain, they are trying to avoid that pain. So if I have a cut here on this is my right foot, and I have a cut here on my right foot. Whenever I step on this, I have pain. Ouch! So you reduce that time that you spend on this side, right? So that is what happens. So you don't want to bear weight on it for long. So think someone has an acute ankle sprain or a hip osteoarthritis, they get on and off the limb as fast as possible. So if you have a pain on this side, you will tip and then you try to put most of the weight on the left side, right? Suppose here, I want you to think here for some time. What's a single word that should come to your mind whenever you say an Antalgic in NPTE? And that is pain. So Antalgic is pain. This is what you need to fix it in your mind, right? So shortened stand phase is pain driven. So because of the pain, you will have very less time that you're spending on the right foot. So there is a shortened stance phase that this will be pain driven. So we are looking at a question here. A patient with the right hip osteoarthritis demonstrated decreased stance times on the right lower extremity. Which gait pattern is this? So patient has the right hip osteoarthritis. So patient is telling there can be pain with osteoarthritis, right? And think that there is a decreased stance phase. So the amount of time, the stance time that they spend on the right feet is less. So what is the gait pattern there? Is it Trendelenburg? Is it Antalgic? Is it Steppage? Is it Circumduction? It is going to be Antalgic, right? So it's B, Antalgic. The giveaway is decreased stance time. So if you say that they have decreased stance time on the right lower extremity and the pain is on the right hip. So decreased stance time, which always point to pain avoidance, and this is not a weakness. So Antalgic gain is always related to pain. So if someone's stance phase is reduced, that's because of the pain is there. Pain is the stance phase is reduced, that is leading to the Antalgic gait. Now, so I hope you understood the Antalgic gait. Now we are going into another one which is really interesting here. Is called Trendelenburg gait. This is a very common one that you can expect on the exam. So Trendelenburg gait happens because of the glute medius weakness on the stance side. When the hip can stabilize the pelvic drop on the opposite side during the swing phase. So what you need to understand is the hip is dropping on this side because there is a weakness on the other side, glute medius. So if the right side hip is dropping, that is because of the weakness of glute medius on the left side. When hip can stabilize the pelvis drop, because the muscles on this side need to pull this way, pull this down, so this side will go up. So if the right hip is dropping, that means the left glute medius is weak. So that's what you need to understand. When hip can stabilize the pelvis drop on the opposite side during the swing phase. So when patient is trying to lift their leg up during that swing, the hip will drop on this side because of the weakness on this side. So if right side is dropping, the left side hip glute medius is weaker. So if the right glute medius is weak, pelvic drop on the left during the left swing phase. That is the trick students get backwards. Before I say the answer, which side is weak, the side that drop or the side that is standing? So it's always stand is the standing side, because if you see it dropping on if I'm standing like this and my hip is dropping this side, it is the weakness is on this side. So the one I'm standing on is this side. Gluteus medius is weak. So it's the stand side, hip abductors are weak and the contralateral pelvic will drop. So we can do a question on that. During gait, a patient pelvic drop on the left side during the gait, during right lower extremity swing phase, which most likely the weak. So it says left side the pelvic is dropping and right lower extremity swing phase. Patient's pelvic drop on the left side. So left side is dropping. So what is happening here? Which muscle is most likely is it left glute medius is weak, or is it right gluteus medius, or right gluteus maximum, or left hip flexors? On count of 1, 2, and 3, we are going to the answer. It's B. So this right. So if left side is dropping, it is right. The opposite muscle side is weak. So right gluteus medius. Remember, drop happens opposite weak side, because the weak side is one standing and failing to stabilize. So remember, the leg that you're standing on, stance leg muscle will be the weaker, opposite to the hip dropping muscle, that will be the one involved side. Okay. Now the another one is very common, is called steppage gait. Steppage gait is caused by dorsiflexor weakness, usually from a common peroneal nerve injury. Remember this, steppage gait, you need to remember peroneal nerve or an L4, L5 nerve root involvement, because this is a dermatoma of that, right? Foot drop during the swing. So the patient exaggerate hip knee flexion to clear the ground. So normal gait, this is there. So what happen is the inability to lift. So they will drop their foot like that. They won't be able to lift it. Why? Two chances: a common peroneal nerve injury or L5 nerve root involvement. So when this is not there, they cannot clear the ground. So what they do, they lift the hip or knee up. So the patient exaggerate hip and knee flexion to clear the ground. That is called the steppage gait. So picture someone lifting their knee unusually high, almost like climbing invisible stairs, just to keep the toes from catching the floor. So instead of touching the floor, they will lift their hip and knee up unusually high to clear the toes from the ground. So now you already know 3 patterns. Antalgic equals pain, Trendelenburg equals glute medius weakness, steppage equals foot drop from dorsiflexor weakness. Very good. You're doing really good. Now we're going for another question. So this is a patient exhibit excessive hip knee flexion during swing phase, slaps the foot down at initial contact. Which impairment is most likely responsible? Is it hip abductor weakness? Is it ankle dorsiflexor weakness? Is it hip flexor weakness, or quadriceps weakness? That's a pretty easy one. B is a foot slap and extended hip knee flexion are the exact NPTE code words for foot drop and steppage gait. So there is a ankle dorsiflexor weakness that is causing that. Okay. All right, so we are going for the last one. We're going really fast, but I make sure that the concepts are getting you and able to understand this pretty easy, right? So circumduction and hip hiking are 2 different strategies for solving the same problem, whether it is circumduction or hip hiking. So circumduction is there, rotate the leg like that, so it's swinging there and coming. Hip hiking, they are doing this. So these 2 things is coming because of the problem that getting a leg that is too long or too stiff or too weak to swing through off the ground. So getting in leg, whether it's they feel like it's too long, too stiff, or too weak to swing through off the ground. This is usually the time where they get the circumduction. The circumduction swing, the leg outside semicircle, you will see this with the knee stiffness. They are not able to bend the knees. Functional leg difference, they have a difference on their leg length. So longer limb, they need to do a circumduction. Or weak hip flexors, they are not able to bring the hip into flexion. So hip hiking, he usually uses quadratus lumborum to hike the pelvis up and lift the whole leg, often seen when the knee or ankle can bend enough to clear the floor, like with a knee immobilizer or severe knee extensor spasticity. So knee cannot bend, or there is a weakness or spasticity there, and sometimes the patients might have an immobilizer. So when you have this, you need to clear the floor, right? You don't want you cannot drag it. So what they do is hiking there, lifting the whole leg up, and that is done by quadratus lumborum. So now we are trying to do a question there, more practical question. NPT questions will be more like this instead of straightforward questions. So let's look at that. A 68-year-old patient post right total knee arthroplasty ambulate with a noticeable outward circular swing of the right leg and denies pain. Which gait deviation is this? What is most likely cause? So we have an age here. Patient is 68-year-old and has a right knee arthroplasty, noticeable outward circular swing. So they are doing a circumduction of the right leg and there's no pain. What gait deviation is this? What is most likely cause? So since there's no pain, you can already take antalgic gait due to surgical site pain. You can remove that. Trendelenburg due to glute medius weakness. There is no hip drop is happening, so you can take that also. Circumduction gait due to limited knee flexion can be a good one. A steppage gait due to peroneal nerve palsy does not say anything. So this state 2 can come down to actually a reason, because think about that. If they go for a surgery and it injure the peroneal nerve, that might lead to what? Foot drop, because there's a peroneal nerve injury, which can lead to a steppage gait 2. Right? So you come down to 2 answer. You need to know which one will be likely be the answer. This is what is tricky. This is circumduction gait due to limited knee flexion or steppage gait due to peroneal nerve palsy. So on count of 1, 2, and 3. So you are eliminating the for question A. The question specifically says denies pain. So pain avoidance patterns are out. Eliminate B. No mention of pelvic drop. Eliminate D. No mention of foot drop or foot slap. So if you go back to the question, there's only circular swing of the right leg and denies pain. Which gait deviation is this? They don't talk about a foot drop, so you can eliminate the D also. So you come down to at least with the C, circumduction gait due to limited knee flexion, which makes sense after knee replacement when knee bending hasn't returned yet, because there's an hypertrophy state. So that's how you eliminate. If you can eliminate the right, you can come to the right answer. So here is one simple way to never confuse these again. Ask yourself 3 questions. 1. Is there any pain? If pain, there's Antalgic gait. 2. Does the pelvic drop? If there is a Trendelenburg, and remember its opposite side is the weak. The stands face side will be the weak. 3. Does the foot drop or slap? If yes, Steppage. Is there a peroneal nerve injury? That or L4, L5 dermatome. If none of those fit, the leg is swinging out or the whole pelvis is hiking up, you're looking at circumduction or hip hiking. A leg that is too long, stiff or heavy to swing through normally. Okay, now that you understand these gait deviations, the next topic you should study is prosthetic and orthotic gait deviation. A lot of questions can be coming from prosthetic and orthotic gait deviation because I was testing those the exact same way. So we are trying to watch that. The next video we will see you on prosthetic and orthotic gait deviation.